about lymphangiography and thoracic duct embolization for chylothorax. I have no disclosures. So just a brief overview of the function of lymphatic fluid. So it does function to return excess interstitial fluid to the blood. So usually about 1 to 2 liters per day cycling through the system. It transports fats and fat-soluble vitamins from the digestive system to the venous system. And it also functions to circulate pathogens through the immune system. Chylous leaks, the most common location is into the chest, so chylothorax, which is the emphasis of my talk today. But we can also see chylous leaks into pericardium, into the peritoneum, as in the case of chylous ascites, and also this rare entity called plastic bronchitis, where we see leak of lymphatic fluid into the airways, and patients expectorate these very dramatic bronchial casts. Lymphangiography is also performed in some patients in some centers for protein-losing enteropathies, where leaks into the intestines create malnutrition for patients. Most commonly for chylothorax, the cause was a recent surgical intervention, esophagectomy, lobectomy, or thyroidectomy with neck dissection. A small percentage of chylothorax cases are spontaneous, and in these situations, typically related to malignant obstruction of lymphatics. Chylothorax occurs in just a small percentage of thoracic surgeries, so it's a relatively uncommon diagnosis, but can be quite morbid for these patients. Persistent leaks can cause immunodeficiencies or malnutrition, and can carry a mortality rate of up to 50% with just conservative management. So there's a strong interest to perform an intervention to treat these leaks. Fluid studies for diagnosis include a typical milky appearance of the fluid. Triglycerides is the first test that is usually sent, and triglyceride level greater than 110 is strongly suggestive of chylous fluid. Less than 50 strongly contradicts this diagnosis. And then you can go on to test for lymphocyte predominance, and then chylomicrons can be positive, but that test takes much longer, and so it's not typically sent unless there's a major question. MR lymphangiography is performed in some centers and can be useful, mostly for non-traumatic chylothorax, where you don't have a suspected etiology, and in neonates. It can also be useful in plastic bronchitis, where we have some suspicion that there's some atypical anatomic etiology. Lymphoscintigraphy is less useful for leaks, and overall, it is most often used for lymphedema diagnosis, although aside from making the diagnosis, which usually you can do clinically, is not incredibly useful. So patients are initially approached with conservative management, which includes a low-fat diet consisting of medium chain triglycerides, lipid-free TPN, and octreotide. Success rates of conservative management vary greatly, and it probably relates to the level of output, so how much fluid is leaking per day, and the response to conservative management. Interventions include surgical ligation, which is usually a large procedure, particularly if these patients are already post-operative, and so they're placed at a higher risk for repeat intervention. Pleurodesis can be performed. Pleuroperitoneal shunts are rarely performed, and then in institutions where it is offered, thoracic duct embolization is a minimally invasive treatment option. Surgical intervention is associated, again, with high morbidity and mortality. And so where possible, to avoid repeat surgical intervention is ideal. So lymphangiography and thoracic duct embolization was first described in 1998 by Cope, and this was a technique using pedal lymphangiography. They had a high clinical success rate. It was associated with a long procedure. So for this technique, which I personally haven't actually been involved in, they inject, methylene blue is injected between the webs of the toes until a lymphatic channel in the dorsum of the foot is identified. A cut down is made, and this duct is cannulated. after which the Lymphatic, which is an oily contrast material, is then injected and monitored as it advances up the legs, lymphatics, into the abdomen, and finally into the thoracic duct. So as you can imagine, this is an oily contrast. It takes a long time to travel up. And so this was a very long procedure starting from the feet. So thankfully, in 2011, intranodal lymphangiography was introduced, which significantly reduced the time of the procedure and also reduced the potential risk of infection with the incision and the technical skill needed to perform a cut down and closure in the foot. Contraindications for lymphangiography are few: uncorrectable coagulopathy, pregnancy, and infection overlying tissues being the main contraindications. One example case that I have is from my training, a 90-year-old male who was post-op day 8 after resection of a large left thyroid tumor. This included the need for left innominate vein repair. He had a left neck drain with output of 500 to 800 milliliters over 24 hours. Pre-procedure, he was given ANSEF, which is the standard. And so then going into the technique a bit, under ultrasound guidance, we placed small needles, 25 gauge needles, into inguinal lymph nodes, one on each side. And so you can see on the ultrasound here, the needle accessing this lymph node. You want to place the tip of the needle at the junction of the hilum and the cortex for more optimal opacification. And you want to have some amount of tunneling in the subcutaneous tissues to make the needle very stable, because you're going, again, it does still take a while for the Lymphatic to travel up into the retroperitoneal lymphatics. And so you want to make sure that those needles are stable. We use small needles and large syringes to make sure that the injection is slow. You want to inject about 1 to 2 milliliters over 5 minutes in order to prevent extravasation or dislodgement of your needle from the lymph node. So it can take a while, anywhere from 1 to 4 hours, to see the Lymphatic reach the Cisterna chyli, which is our next intervention step. So this is a picture just showing the typical appearance of the lymphatics, this sort of beaded appearance, kind of web-like. There's some lymph nodes you can see filling here. There are various techniques that are described to try to speed up this process. I always use sequential compression devices on the calves as one of my go-tos. Again, then the next step is to look for the Cisterna chyli, which, as you may remember, is a triangular sac-like structure in the upper abdomen located posterior to the aorta at the level of T12 to L2. So this is a very thin Cisterna chyli, and this is somewhat easier to access, larger triangular appearance of another patient. And then under fluoroscopy, we guide a very small needle, 21 to 22 gauge Chiba, from a percutaneous epigastric location into that duct. And the key is to, under fluoroscopy, guide your needle all the way down. The Cisterna chyli is located immediately adjacent to the vertebral body. And so you really want to pin the duct to the vertebral body, and then you slowly back the needle out as you advance a small wire, 0.18 inch wire or smaller. If you're in the duct, or if you're not in the duct, you'll see it go kind of to the side and it will curl up. If you're in the duct, you'll see it fly straight superiorly. So this is just a picture, and you can put a little bend on the tip of the needle to give yourself some directionality, as long as you make sure that the wire will still advance through that needle. And then when you know you're in the duct, the wire slides very smoothly and straight superiorly. So then we exchange the needle bareback for a microcatheter, which we then advance into the lower thoracic duct and inject regular water-soluble contrast. So this is that same patient injecting the contrast, and we can see around the neck drain that he had a leak of contrast into the subcutaneous tissues and draining through that tube. So at this point, it's important to recognize there are multiple anatomic variants. Most commonly, we see a single duct draining into the left subclavian vein, but you can have a dominant right lymphatic duct, you can have duplication of the duct. You can have a complex webbed appearance of the duct, and I have an example of that in a little bit later, which can make the embolization procedure understandably much more difficult. This particular patient, though, had the standard anatomy, a single thoracic duct. We then embolized using a combination of coils and NBCA glue. This combination has been found to be the most successful in creating a good plug within the thoracic duct. The glue, as you may recall, requires some ionization to polymerize, and that is not often found within the thoracic duct. And so the coils create a scaffolding to hold that glue in place. We use a thick concentration of glue, 1:1 to 1:2 ratio with the piedol, so that we can visualize, and so that, again, it doesn't embolize if there is still communication with the subclavian vein. Before injecting the glue, of course, you want to prime your catheter with D5W solution, a very small volume, so that the glue doesn't polymerize within the catheter itself. And then as you're injecting the glue, we're pulling back slowly. Where you get close to your access site into the cisterna chyli, then you start to aspirate and remove the catheter immediately to prevent laying of glue along the tract in the abdomen. This particular patient responded very well. His output had reduced to less than 100 milliliters on the first day, and we were able to remove the drain by day 4. Lymphangiography alone, even without thoracic duct embolization, has been shown to be therapeutic. So not only is it a diagnostic entity, but it can be therapeutic, which is useful. This is most often successful in low volume output leaks, less than 500 milliliters per day. For high volume output, there's still a good amount of success with just lymphangiography alone. So if you don't see cisterna chyli, or if you can't access it, it's still encouraging to be able to tell the patient and the clinical teams that they may see some success from your procedure, even if you're not able to embolize. Some more data about success rates. There's this other entity called thoracic duct disruption. So as you're attempting to access the cisterna chyli, occasionally, if you're not able to get in, at some point you no longer see the duct or the cisterna chyli opacifying with your lopiodol. And so then even this is felt to be related to, rather than true disruption, more compression by adjacent hematoma perhaps, or inflammation. And it actually improves the response rate of the procedure. And so it's worth attempting to get into cisterna chyli, even if not successful, because it can improve the rate of success for overall. Time to resolution varies, and of course it depends whether you've just done lymphangiography, the disruption, or embolization. Even with embolization, sometimes we see a more prolonged response time, which can be frustrating, but it's sometimes you just have to be patient. In the post-surgical setting, leaks less than 500 milliliters per day, there is a study that's showing similar success and time to resolution for lymphangiography alone versus lymphangiography with embolization if no leak is visualized. And so there are some who feel that if you can get into the cisterna chyli in the thoracic duct, you should just embolize because you're there. But there is data showing that if you see no leak, it may be worthwhile just seeing how they do without the embolization. Complications, we went over a little bit, infection at the pedal axis in particular. Lymphedema and chronic diarrhea are seen in about 8% of patients. And so that's an important conversation to have, although again, these patients are often feeling quite frustrated or feeling very sick from the leaks. And so these low rates of complications are less of a concern. Chylous ascites is a very low complication related to embolization. And then also embolization of glue to the pulmonary arteries. And this is, of course, when there's still communication of the duct with the left subclavian vein. I actually have seen a colleague, this happened to one of my colleagues. There was quite rapid flow when injecting contrast, and the glue in a very small patient. And so that's something to watch for. And again, why the coils can be useful to create a scaffolding to hold that glue in place. There are recommendations on total volume of Lipiodol that should be injected. So reported volumes and recommendations are somewhere up to 15 milliliters. There's a body weight max that's been proposed, which is useful if doing pediatric cases. High volumes have been shown to have some complications, such as symptomatic PE. Again, if you have this Lipiodol traveling through the system, it empties into the subclavian vein and ultimately ends up in the lungs portion of it. And then there was this one case of cerebral embolization with high doses, although this is probably more related to the presence of a shunt. And then in pediatric patients, hypothyroidism has been experienced. So I have another case of plastic bronchitis. This was a 33-year-old male with acute onset of cough and expectoration of bronchial cas. This was a picture that he submitted. He underwent an extensive workup, including lavage, which showed high lymphocytes. He also presented with an incidental testicular mass. And so there was an extensive workup from any evidence of metastasis. This was found to be a pure seminoma, and he was not found at any point to have any metastasis. But he did undergo a wedge lung biopsy, which showed inflammatory changes and no malignancy. So he came to us for lymphangiography, and already you can see his thoracic duct is quite more complex than the first case that I showed. He had probably 2 or 3 channels that we interrogated with our microcatheter to attempt to identify a potential leak. You can see this complex sort of duplicated thoracic duct with some webbing. You can also see what's classically seen in these patients with plastic bronchitis with retrograde flow into the peribronchial lymphatics. So typically you won't see these peribronchial lymphatics because the flow should be antegrade into the thoracic duct. The etiology for plastic bronchitis is not known. It's felt to relate to potentially some congenital variant in lymphatic anatomy, which is then triggered or irritated by a viral respiratory illness, for example, that then creates some scarring or some abnormality that results or precipitates a leak. And so this patient, we obviously don't screen for congenital abnormalities, but he did have a respiratory illness that then seemed to bring this on. So you can see again these complex lymphatics in the region of the airways, and then no specific leak that we identified, but we did go on to embolize, placing some coils near the thoracic duct terminus and then laying glue back along the main channel that seemed to be leading to this site. There was extension of glue into these abnormal lymphatics, and he did respond very well to this procedure with cessation of this expectoration within the next couple of days. There are some who advocate in this scenario embolizing only the abnormal lymphatics that you see. So you may not have to embolize the entire thoracic duct in the setting of plastic bronchitis, especially if you can get into the abnormal lymphatics. And this may serve to preserve, the normal flow of lymphatics through the thoracic duct. I'm not sure that we entirely know where the rerouted lymphatics drain, and it's a little bit disconcerting to be able to, or to explain that to a patient. But again, they're often in a very difficult spot. And so I just explained to them, we just don't know, but it seems that in most patients, they don't get this chronic diarrhea or lymphedema. And so there is some rerouting of lymphatic flow back into the normal system. There are a couple different techniques or alternate techniques for access. If you can't, first of all, if you don't see a Cisterna chyli, or if you can't access the Cisterna chyli but want to search for a site of leak, This article describes ultrasound-guided direct puncture into the thoracic duct. So visualizing with ultrasound the thoracic duct terminus in the neck, performing lymphangiography. So they use a micropuncture needle under ultrasound and a 3 French introducer dilator to get into that duct. These are pictures from their article showing what a healthy thoracic duct terminus looks like, anechoic, thin-walled, and then unhealthy, you start to see more echogenicities and thick-walled appearance. Once you have your Lymphatic, if the Lymphatic is traveling into the thoracic duct, under ultrasound, you can see the Lymphatic as an echogenic material flowing through the thoracic duct. Otherwise, it can be challenging to identify. They have nice pictures here. The duct terminus is usually located between the internal jugular vein and the vertebral vein, but sometimes you can't quite determine whether an anechoic structure that you see is a vessel versus the thoracic duct. And so that can be challenging if you don't have Lymphatic in the thoracic duct terminus. If you do, again, have Lymphatic in the thoracic duct terminus, it's relatively straightforward to access under fluoroscopic guidance. I would recommend using a combination of fluoroscopy and ultrasound because there are major vessels in this region. This was a case where I managed to access retrograde, and you can see my microwire going inferiorly. I have had a case where I was not using ultrasound, and I did access through and through the carotid. The patient had no neurologic sequela post-procedure, but needless to say, this is not ideal, and why I advocate for a combination of ultrasound and fluoroscopy in this situation. It can also be, particularly when you have opacification of the thoracic duct terminus, useful to come from an upper extremity venous access, so coming transvenous with a reverse curve catheter or a Comfy catheter to gain access into the terminus. And this can be challenging in and of itself, especially if you don't have opacification of the duct, because there is a valve that prevents retrograde flow of blood into the thoracic duct, which is working against you. This is a case of some former partners of mine where they did go retrograde. They were able to come antegrade, opacify, ultimately get a catheter through the thoracic duct terminus into the subclavian vein, where they then snared a wire that they had coming from the upper extremity vein to get through and through access, basically from the epigastrium, the cisterna chyli, through to an upper extremity vein to assist them in this procedure. This was a case that they described of using a Stent-Graft to exclude a leak in a patient with Chylothorax, which is not commonly performed. And this was a similar case that they did using Stent-Graft reconstruction for a patient with chylopericardium. So as I mentioned, Stent-Graft reconstruction of thoracic duct is kind of a theoretical attempt to preserve flow through the thoracic duct. This is not performed in many institutions, and we don't really have data as to long-term outcomes for these patients. I think the overall consensus from what I have heard is that these stents probably occlude at some point, but we just don't know. And as you can imagine, it also is somewhat a challenging procedure. Not so much for chylothorax, but for some patients who have lymphatic leaks or chronic lymphoceles, performing lymphangiography in the region of a drain can be useful. This was a particular patient who had a lymphocele with high output after some inguinal node dissection. Actually, I'm not sure why he ended up having this leak, but the authors here accessed the lymph node under ultrasound, injected contrast or Lymphatic, and could identify the site of leak. And so they treated this with glue embolization of the lymph node, which was able to successfully stop this leak and have the drain be able to be removed. There is another technique that's been described for chylous ascites. So Chylous can be a tricky entity. Initial approach is through intranodal lymphangiography. If you don't see the site of leak, though, this is a technique that was described where where the authors used balloon occlusion to identify the source of leak. And so again, they got antegrade access into cisterna chyli, upper extremity venous access, snared a wire to get through and through access so that they could place a balloon occlusion catheter and inject contrast and see the leak. And so here they were able to see that leak and treated with sclerotherapy using sotradecol and lepiodol. And I think it took a little bit of a while, but this was successful in treating for this patient. And this might be my final case, but this is a 22-year-old female with a history of chylothorax after a redo neck exploration. So she had an unfortunate case of thoracic outlet syndrome after a horse riding accident. She had rib resection with recurrence of symptoms. They took her back for surgery again. And then unfortunately developed high output chylothorax. The fluid was milky in appearance with high triglycerides. And rather than taking her back for another surgery, she came to us for lymphangiography. So these are images from her lymphangiogram showing some of the abdominal lymphatics. She had a very thin retroperitoneal channel. I'm not even sure if you would call it a cisterna chyli, but we were able to access that. And again, we saw a complex anatomy of her lymphatics, whether it was congenital or related to her postoperative state, I'm not sure. But we basically saw this one main channel that led up to this upper leak. So you can see this bubble of the lepiodol pooling in the left neck. And then at a certain point, the contrast refluxed down into this other channel that was very close to where we accessed the cisterna chyli into the second channel that led to some of these abnormal lymphatics and then a leak in slightly more inferiorly. So we did embolize the main channel. We placed some coils and then we embolized with glue, which we then were able to see reflux again into the lower portion of that second duct. And so we hoped that that would have good effect for her as opposed to trying to cannulate the second duct and embolize that separately. She initially responded very well with a reduction to something like 50 mLs a day, but then it actually increased. Interesting, the fluid turned from that milky appearance to a more serous appearance. And so the question is, whether this was persistent leak or whether it was related to something else. She was continued with conservative management with midodrine actually, and TPN and a low-fat diet. We actually brought her back to attempt repeat lymphangiography, which can be done, but she had very small inguinal lymph nodes. That makes it really challenging, especially after you've done one lymphangiogram. Sometimes or often that lepiodol stays within the lymph nodes. And so it's hard to get more into the same lymph node. So it's nice to be able to have other lymph nodes as options. I had recently, one of the SIR forums was discussing what you do in this situation when you have either no or very small inguinal lymph nodes. And there was one interventional radiologist in Texas who reported that in all of his lymphangiograms, he does transhepatic access now because he has found this to be a more rapid way to opacify lymphatics. So for her, I attempted this, but was not successful. That can be very challenging because you're basically attempting to place a needle into the lymphatics around the portal vein and opacify. You obviously don't want to use lepiodol in that situation because if you're in the portal vein or some other venous structure, you don't want that lepiodol to embolize. And so, unfortunately, we had a very nice technical success rate, response or appearance in this case. But clinically, it was a little bit confusing because of the change in the nature of the fluid, but that she still had this high output. After several weeks, she was able to have the chest tube removed. The fluid did reduce in volume, and she now no longer has this leak of fluid, but not quite as rapid a response as we might have preferred. So in conclusion, lymphangiography is an excellent diagnostic and therapeutic tool with a low risk of complications. It can be technically challenging, especially if you have to resort to any of these alternate access types. But in these settings, it can be reassuring that lymphangiography alone can be therapeutic, and with practice, success for these different techniques can increase over time. So thank you for your time, and I'm happy to take any questions.